Thank you, everyone. Okay, I'm just going to get organized a little bit on this side. So materials made possible through a financial contribution from Health Canada, and views expressed here does not necessarily represent the views of Health Canada. So in terms of disclosures, I'm employed by a community pharmacy, also with some association work with facilitation, giving pharmacy manager talks and some grant collaboration, of course, and also honorarium for preparing the content and presenting at today's session. So commercial support, financial grant, like we had mentioned, with all of our ECHO sessions and in-kind support from the BCCSU hosting the program in terms of logistic support with our team here. Mitigating biases, reviewed for potential biases and validated by members of an independent scientific committee and also the College of Family Physicians of Canada. And it is approved for accreditation submission. So do please note your name and affiliations in the chat so that you can get your CE credits as well. So learning objectives, there's a lot, but don't worry. These slides are available for you, just like our other slide decks. Describe the OAT options and briefly really go over the methadone formulations again for those that are on the line. Pharmanet, how it's used in the pharmacy setting and what types of information that we as pharmacists might require from the prescribers. There's a new drug-drug interaction table that some members of our writing team put together as well. So we'll be presenting that, and you can also see it on our website. Common errors, just as a reminder of some things that will stop the prescription potentially at the site of dispense, and just to make it easier for the patients. And then of course, some of the Controlled Drugs and Substances Act exemptions, which has changed a little bit over the year because of the COVID. The new duplicate prescription forms, just a quick update and some logistics for you. And I'll also go over some other things really briefly. So again, the slide deck is available for you. Oral overview, I'm going to go over the buprenorphine naloxone, methadone, the slow release oral morphine in the form of Cadian. Briefly, the injectable formulations are available out there right now. As you know, hydromorphone injections that the programs have been expanding throughout the province and as well in other provinces. Diacetylmorphine is available at Crosstown Clinic, which is a heroin. The program is still available. And also lately, since last summer, you heard about the extended release buprenorphine, which is administered subcutaneously. So methadone formulation options, just as an option to be aware, there's methadose, which is the pink color. Methadol D is clear, which is mixed with Tang or other substances to make it more drinkable, apple juice, or even sugar-free Crystal Light. And there's a Sandoz methadone, which is blue in color. Regular benefits, if there is ever an issue with benefits, you can always connect with the pharmacist as well. Compounded methadone is a non-benefit, exceptional last resort. There is a bulletin in place for that, and we can provide that as a resource a little bit later on at the end of the packages when we send it to you. And switching one methadone formulation to another, there is something that has happened where changes should be in consultation with the patient and prescriber where possible. And technically speaking, they're interchangeable, but there was a bulletin put out by Health Canada that any changes can destabilize certain populations. So a discussion would be ideal. As a reminder, Pharmanet is actually a dispensation record. It's not a medication administration record. So that's very different. So for example, if pharmacy does dispense a medication, it's written on the Pharmanet. However, whether or not that person took the medication, it can vary. If it's a daily witness ingestion at the pharmacy, most likely it has been taken. There's also product identification pins, which vary according to delivery and witness doses for ingestion. And if you Google, and I can't believe I'm saying Google, but you can Google the OAT and pin numbers actually, and we will also provide that for you in case you're interested in knowing about it. And when you're looking at Pharmanet for some of our RN prescribers, just reiterating that tablets or capsules are entered by number of tablets or capsules, and liquids are by volume. So those are some things that we've gone over just to make sure that you're familiar with what you see on Pharmanet. And if you need to identify the pharmacy that fills the prescriptions, it's actually not on Pharmanet itself. You actually have to ask the patient or call. There's a Pharmanet medical practitioner line as well that is available, and you need your college ID, and we could provide that line for you. These are codes that pharmacy does use. In terms of on your actual EMR, different EMRs differ. So depending on what you use, you could have a reversal on your end. And these are codes that if you dig a little bit deeper, it may or may not be on your EMR depending on the programming. There's also conformance standards that needs to be updated on almost all the EMRs, which will be forthcoming a little bit later on. But these are some things that the meaning of some of these codes or when things were not picked up or renewed, etc. So this is available for you. So in terms of central system depressants is really using caution. And these are things that we've talked about over the time that we've been here in different sessions. So minimum requirements, monitoring patients for sedation and respiratory depression, which is really important, especially simply because there's a lot of things that are out there in the mix of the fentanyl medications out there that people might be buying in terms of benzos as well. So alcohol is a big one as well. So medications containing alcohol is contraindicated, but ask what individuals are taking. And of course, naltrexone. This is something we're flagging right now. It's contraindicated for OAT therapy, and this is particularly important when there are multiple prescribers, or perhaps somebody has kept the naltrexone to look at it or to use it a little bit later for alcohol use disorder. Really, really important to have this check in place, simply because there has been instances where a person has gone through precipitated withdrawal. This is a table really generically in terms of drug-drug interactions being present, and that is available for you in a more fulsome table that we can provide the link to at the end of the presentation. So what's really important for just some hints and tips, of course, and I still see this once in a while for writing journal tips, is don't end it on the day before a stat holiday or weekend if the pharmacy is closed, of course. Indicate specific dates for carries. The issue is when carry stat holidays or carries when closed, it can differ and it means a different thing, meaning to different pharmacies. So specific dates are really important. And how to proceed if doses have been missed, because we cannot actually as pharmacists unilaterally change those prescriptions. We can't drop a person to 50%. We can't do any of that. So be very specific in what to do and indicate on the actual prescription. However, if the patient actually refused to take the entire dose, that we document and notify the prescriber. And again, co-prescribing, do write down, we'll go over some points about this, do write down that it is okay to dispense as is and that you are aware that the patient is on different medications. And then any other specific instructions to write up, and duplicate prescriptions, of course, if there's any changes, etc. For corrections. Currently right now as it stands, the prescribers have to rewrite for a new duplicate if there are corrections to be done on buprenorphine, naloxone, or the slow release oral morphine as it stands right now based on the requirements. This is just an example for you, just to have on hand if this is a new deck for you to keep on hand for you. Just some hints, etc., for writing prescriptions for our RN colleagues. You have your fulsome workbook that we've included some of these samples for. Microdosing, yes, it is hard to type on the duplicate. Ideally, typing depending on your EMR is great. Instructions for continuing under OAT while up titrating is important, and dates, schedules for carries. What's really important for microdosing is instructions for missed doses. What does the pharmacy need to do? But also, what does the patient need to do if they're doing home inductions at home, as an example for microdosing? Oftentimes, if the prescribers are not there all the time, where like in a rural health practice, sometimes people are there for 2 days a week, it's really important to instruct the pharmacy as well as the patient on what to do should a precipitated withdrawal happens, or should more than 1 or 2 missed doses happen in the microdosing situation. Methadone prescription examples. This is an example on the top right there. There's a home delivery field for deliveries that is allowed prior to April 1st, 2020. Prescriber authorization is actually no longer required. If you do not want a delivery, you can actually write no delivery. This is exactly what happened many years ago when the pharmacists had the ability to decide delivery or not. And again, just some hints: quantity, date range. The quantity must match the date range. Sometimes errors do happen. If you notice this in your practice, just double check with the MOAs as well, because sometimes the MOAs do finish some of the work for the prescribers for you. And formulation, if required, for example, methadone D, that is no longer required. But if you want to be sure that this patient gets methadone D, you could write that down. And again, we mentioned that formulations were interchangeable, but it is also best practice for the pharmacist to actually go back to the prescriber to inform of any changes and also to discuss with the patient. This is another example of OAT for SROM, and you have to write for OAT or OAT. That is a requirement. Otherwise, they'll be tagged as a pain therapy, and it is required for opioid agonist treatment. And this is just, again, an example of best practice to write the prescription. It is available for you. When the new duplicates come, there will be more room, and there'll be more of a matching of all the OAT writing. The harmonized controlled prescription form is coming. So instead of the pink form and the blue form, you'll have one form. So this is for prescribing of all Schedule 1A medications. And it's really making it consistent to writing. There's a little bit more room for some writing, and also reducing some of the burden associated with different prescription pads. And there will be a plan out from all our colleges on this, so not to worry about it. It won't just switch overnight. There's a plan in place for sure. So just as a reminder, if the OAT dosage is changed, you indicate on the script. If changes are required before the prescription end date, midway through, if you just write cancel OAT prescriptions, it just makes it so much easier to prevent the 2 active prescriptions in the setting, in the community setting. Because sometimes, what if the patient never showed up on that one day and they missed 1 day or something like that? There's another active prescription out there, and sometimes the patient could go to 2 different pharmacies simply because maybe they're closer to another pharmacy when they get the second prescription. If the patient's being admitted to a hospital facility, definitely we see more of this now, that the community pharmacy is engaged into to notify that the patient is inside the hospital and to cancel current prescriptions. Really important way to loop the extender of the team into understanding that this patient is in the hospital, because sometimes we're actually looking for the patient in a community setting, not knowing what happened. And then plans for discharge is definitely important. So communications, there's a communication form that we can provide a link to for a pharmacist to prescribe a communication form for methadone. There's no need for the prescriber to write a new duplicate at all. There's an emergency fax documentation form as well. So anything that is corrected on this form, totally fine. Right now, as it stands, and I did mention that any changes to a form for buprenorphine naloxone or for a form for the Cadian or the slow release oral morphine, you need to rewrite a new prescription based on the requirements right now. And then right now with the COVID situation, Health Canada had an exemption to the Controlled Drugs and Substances Act, which is also known as the CDSA. So prescribers can issue a verbal order over the phone. We just need, as pharmacists, the actual hard copy of the duplicate afterwards. Pharmacists in BC, we've always been able to provide an emergency supply of medication, including some narcotics, based on the assessment on our end. So it doesn't mean that we will do it. It's just we have to assess it properly and document it properly. We're also allowed to transfer prescriptions of narcotics to other pharmacies now, which is amazing because it will help the treatment and help the pathway for the patient to make it easier if they move somewhere else, or if they're, you know, going home or at another place that's nearer to them. And also pharmacy employees are allowed to deliver prescriptions to a patient right now, compared to before where it was only pharmacist. This is just to ease some of the restrictions with COVID and to make it easier for patients to access care. Logistics wise, administrating OAT. So it's up to you as a prescriber whether or not the first dose should be witnessed or not. And essentially, at a pharmacy point of view, all we have to witness is have the patient to put the tablet under the tongue. That's the only requirement. That being said, though, it's really, really important to ensure that the patients know how to take sublingual tablets, because oftentimes it's here where a person might not hold the tablet long enough to dissolve completely. They sometimes do swallow, and so the targeted dose might not be at target. So first dose of methadone or SRAM must be witnessed right now, and not use their own drinkware during witness ingestion. So what we do at the pharmacy end is measure the doses and provide it to the patient. Methadose, the pink one, and Sandoz methadone, the blue one, does not need to be diluted. It can be mixed with a bit of water. Methadone D, it has to be diluted to 100 mils, to 100 mils in total, either the orange flavored Tang, the Crystal Light I was talking about, or the apple juice. Slow release oral morphine right now, it does, if it doesn't say no need to open or no need to sprinkle, we have to sprinkle. So just ensure as prescribers, you just write no need to sprinkle, especially in COVID times right now, putting the pellets in mouth followed by a small amount of water. Partial ingestion, if something happens where the patient cannot take their medications, we would communicate to the prescriber, because sometimes patients, they know themselves enough that they will say, you know what, I only want to take this much. And that is a requirement from the pharmacy side to notify the prescriber as soon as possible, because something else might be going on or the patient's not as comfortable, just to make sure that the patient is being taken care of. Limited doses, of course, definitely need to contact the prescriber, and then replacements. Ideally, a replacement script would be ideal, simply because we have to match narcotic reconciliations on our end to a script. So that's why the point down there, it's easier for a pharmacy if a new script is written, just in case. Medication shortages. I wanted to go over this a little bit more because there's so many medication shortages right now, not just for OAT potentially, right? Also other cases. So there is a Drug Shortages Canada website that you could bookmark if you ever need to. And on there, it's a requirement from the manufacturers to actually look at potential shortages, actual shortages, if shortages have been resolved. And it can be due to many, many things, either drug utilization increases, meaning there's more people using it. There could be supply issues, meaning maybe there's import-export issues, or supply of even a bottle, or labeling requirements, or a result of some of the supply chain management. What that means is that perhaps at different locations, either in the wholesaler level or at the actual pharmacy level, maybe there wasn't enough kept on stock to help patients that are new to the area. So if you notice a shortage at all, it's so important that you just don't ignore it. contact the pharmacare line or the provincial plan entity, wherever you are, or the country entity, because at a higher level, there's higher level people that are looking at allocations of medications. So if nobody knows until the last minute, then there's a panic situation versus an allocation throughout the provinces or a switch. So those are things that are so important that I think as pharmacists, oftentimes you trade with each other or you buy from each other until last moment, or you go from an 8 milligrams to a 4 milligrams, etc. So really important to just notify somebody immediately. Then there's a look at the supply chain issues. And also medication plans, of course, can be made for patients. So an easier transition plan to look at patients or overall for the clinicians that are prescribing, and also for yourselves as pharmacists to look at what you can do at the pharmacy level. Medication shortages, just as a reminder, and I wanted to make sure, because slow release oral morphine is SROM, right? There's two formulations, really need to make sure they're very similar. Cadian, I can use a brand name here because it's Cadian, it says there, 24-hour release kinetics. And then the MS law, a little bit different, 12-hour release kinetics. Why it's important to notify people when there's shortages of either or is because some people may not be as stable on MS lawn, and so maybe there needs to be a look at from a different level to ensure that patients that can carry and safely can carry are able to be prescribed MS lawn, as an example. So these are the differences in some of the formulations. One is a 12-hour, 12 hours, so twice a day dosing, and then the other one is a once a day, 24-hour release dosing. So writing prescriptions for outside BC, and it might be necessary, the patient is traveling outside of BC. And oftentimes we sometimes hear stories where the transition wasn't as good and the patient could be left without a prescription. Definitely connect with out of province pharmacy, out of province physician, if possible, what's out there in case something happens and the patient needs help. Options available, making sure that there's availability from us over to another province or from the province over to here, or even if you're traveling, when traveling restrictions are lifted from other countries, what do you do, right? And then emergencies are really important, especially if stays are extended. And we saw this, unfortunately, the last little while for extensions of stays for some places. Outside of BC, the flip the other way around, other country, including USA, we cannot dispense by Canadian pharmacy. So there needs to be a look at how the person can be transitioned or what resources are available. And I note that some of our colleagues are from the States on this call as well. Other provinces, we have to, as pharmacy, make sure that they're real. And medication coverage, this is something that's very different that people might not be as aware of, is coverage is provincial and it doesn't extend necessarily to other provinces, except there's exceptions, right? Plan W can allow, Plan W is First Nations Health, can allow claims for reimbursement. And so those things should be sorted out before the patient goes to another province. And certain work plans, for sure, they actually work across the country. So just to ensure that that happens. So summary really is, this is a huge deck of slides. It's just for you to update yourselves and have on hand the OAT options currently right now. I haven't spoken about the risk mitigation guidelines at all. We can, there's other sessions on that. Is buprenorphine, naloxone, methadone, the different formulations that are interchangeable, and SROM, making sure that you know that there's two. Pharmacare benefits are available for all of these. Pharmanet, it's a dispensation record, not a medication record. And then other tables that are available, yeah, hopefully the harmonized forms are coming soon. Temporary exemptions are extended so far right now till at least the fall, and we'll revisit that a little bit later on. And again, first dose of methadone and SROM must be witnessed. And other countries and other provinces, there's nuances around there, and it's all about planning, really. There's resources available for charts. There's the drug interactions that our colleagues, the medical writing team, updated. Intervention codes, if you're interested in it, are found on the websites. And again, there's conformance things that need to be looked at for a lot of the EMRs a little bit later on. And then there's the references in terms of why there was a bit of a potential, is potentially a destabilization depending on the interchangeability of the methadone. So that's why it's really important to communicate with everyone on this. Finally, just as a reminder for all colleagues, there are physicians, nurse practitioners, nurses that are colleagues that just joined us in this care, midwives and pharmacists. There is a 24/7 phone line available for clinical questions that's available. And these teams are spread out throughout the province from rural to urban. So there's definitely a lot of different people that can help support you as a clinician out in the community setting.